Welcome to today's NCAS webinar. I'm Ron and I will be your chair for today. The theme of this month's webinar is primary care, as you all know, and we're delighted to have you all join us for this important discussion. Now, before we begin, I'd like to go over a few housekeeping items. So please note that parts of today's session will be recorded. These will be uploaded for those unable to attend live. And we also encourage your active participation throughout the webinar. If you have any questions, please use the Q&A feature in Zoom. Alternatively, if you prefer to ask your questions verbally, you can use the raise hand feature. We will acknowledge you and unmute your microphone when it's your turn to speak. So yes, looking forward to a productive and engaging session. So I'm pleased to introduce our first speaker, Dr. Nour Shamas. Nour is an infectious disease and antimicrobial stewardship clinical pharmacist with a wealth of international experience. She has worked in various healthcare settings across Lebanon, USA, Cambodia, and Saudi Arabia, and brings over 8 years of experience leading AMS programs. Nour is currently a technical and policy consultant on AMS, and has worked with the WHO on scaling up hospital AMS and developing centers of AMS excellence in the Eastern Mediterranean. Her work with WHO headquarters includes updating AMS tools, integrating the AWARE antibiotic book into national settings, surgical prophylaxis, IV to oral switch, and primary healthcare. Adding personal dimension to her professional expertise, Nour is also a member of the WHO Task Force of Antimicrobial Resistant Survivors, having cared for her mother who survived an antimicrobial resistant infection. With her extensive experience and personal connection to the topic, Nour brings a unique and valuable perspective to our discussion today. Our presentation today is titled Antimicrobial Stewardship in Primary Care. What on earth is going on? So please join me in welcoming Nour.
Hello, everyone. Thank you very much for having me, and thank you, Ron, for the kind introduction. I'm excited to be with you on this recorded presentation. I'm sorry I couldn't join for the Q&A, but I look forward to discussing with you antimicrobial stewardship and primary healthcare and sharing with you some interventions happening globally. So the objectives of my talk are to define antimicrobial stewardship and primary healthcare and identify some of the goals of AMS in primary healthcare with some of the barriers and facilitators, and also describe select global practices and trends in antimicrobial use and stewardship. This is by no means a comprehensive review, but I wanted to highlight some specific examples that are I thought were very interesting. And so just going back to basics, the definition of stewardship is the careful and responsible management of something entrusted to one's care. So this, of course, includes natural resources as well as antibiotics and antimicrobials. And this, of course, goes beyond just the hospital setting. And in parallel to define primary healthcare, according to the WHO, it's a whole of society approach to effectively organize and strengthen national health systems and bring together several services, for health and well-being closer to the communities. So basically bringing health to communities rather than bringing communities to health centers. So that's why it's primary healthcare. And it is important that it's integrated, that it addresses the broader determinants of health with multi-sectoral policy and action, and also it's important to empower individuals and families to take charge of their own health. So a big component has to do with health promotion, with disease prevention, treatment, and palliative care, and more. And of course, we in the literature use different terms: primary care, primary health care, outpatient, ambulatory care. And so might also be other terms used in your setting and other settings. So it's important to think of those words whenever we're doing our searches. And also when thinking about the scope of primary healthcare in AMS. So some of the recommendations in different documents pulled in here recommend or suggest that we could implement antimicrobial stewardship in primary care clinics, in outpatient specialty and subspecialty clinics, in urgent care, in dental clinics, and in general for dentists, by dentists, in emergency departments, and particular in to some countries and potentially uh, other specialists in other countries, but for example, nurse practitioners and physician assistants that can prescribe antibiotics, retail health clinics and teams. So basically, any situation where there could be antibiotic prescribing and or potentially dispensing, but mostly prescribing. So why is AMS in primary healthcare worth the trouble? Because I'm sure you've seen a lot of work on in hospital AMS. But actually, most of the antibiotic use in general occurs in primary healthcare, up to 95% in some studies. And a really large proportion of this can be attributed to a few indications like upper respiratory tract infections and diarrhea and urinary tract infections. So that could be a really good place to start. And also, around 50% of these prescriptions are concordant with guidelines or appropriate, and at least a quarter are unnecessary. So there's a lot of room for improvement with relatively non-complicated infections like upper respiratory tract infections, diarrhea, and UTI, as you mentioned. And if you look at the literature, just I did a search string with non-robust search string, but I use the same one, looking at and just compared inpatient or hospital stewardship interventions versus outpatient interventions, and I just wanted to see the difference in how many hits I would get, and there's a big difference. And we still, however, see some important literature outside of the stewardship definition, which wouldn't fall under the literature search I just did showed earlier. But for example, this study looked at in Italy looked at antibiotic prescriptions from 2000 to 2019 in Italy, in a specific part of Italy in Lombardy, for patients above the age of 40, and they found no significant change in trends in prescribing. So this wouldn't necessarily fall under that literature search, but also shows you important information. On the other hand, this study from China and Gansu identified significant reductions in antibiotic use. In figures A, B, and C show total antibiotic use in Gansu in figure A, antibiotic use in public hospitals in figure B, and antibiotic use in primary healthcare in figure C. And you'll see what I highlighted, what I outlined in red is the 2020 numbers, and you can see a stark decrease. And this is because the local government had implemented significant, very structured interventions, and they were able to show a reduction. But the authors still benchmark against international or other countries, and they still identify that their antibiotic use was higher than other places. So there's a lot of room to grow. And often when we think about antibiotic use or antimicrobial use in the community or in primary healthcare, we tend to blame pharmacists. I'm a pharmacist, and that this has always been a very important aspect of my practice and thinking about what our role is in the community as well as in hospital settings as pharmacists, and also the expectation that patients ask for antibiotics. And I usually present this specific article because this was implemented in Saudi Arabia, where I was working for a long time. And it looked at 327 random pharmacies, and they had undercover investigators that went in with signs of clinical illness, specifically for upper respiratory tract infections and UTI in pregnant women. And the study identified that 77% of pharmacists dispensed antibiotics even without a prescription, and 95% of those prescriptions had no patient request. So this basically dispels the myth that patients are requesting antibiotics. This, of course, can be different in different settings, but this was a very important expectation for a lot of the prescribers in Saudi. Another thing is the pharmacists, none of them asked about allergy, and only 23% asked about pregnancy for the patients with UTI, for the investigators with UTI. So yes, of course, pharmacists can have a big role to play in dispensing antibiotics. So because if you start talking to policymakers that you want to implement stewardship in primary healthcare, you may have this discussion of, all right, but what about the pharmacists? And so moving on, this study was, I think, in 2011. And in 2018, the Ministry of Health of Saudi Arabia implemented a very strong restriction policy for dispensing antimicrobials over the counter. They made it basically illegal, with a fine up to 27,000 US dollars and imprisonment up to 6 months, and the potential to revoke their pharmacy license on repeat offenders, basically. And they studied also the impact of this policy, and they found a 17% reduction in antibiotic use from 6.27 DDD per thousand inhabitants per day, DID, to 7.59. Sorry, it's the other way around. It's 7.59 to 6.27. But then they also did a follow-up evaluation called the regression discontinuity, with the regression discontinuity design. And what they found in their evaluation is that actually after implementation, within some time, the numbers went back up. And they identified also that there was no impact in the distribution of antibiotic classes. So they didn't see any basically they were worried in the study. They were worried about the real long-term impact of this regulation. And I think that this just highlights again that regulation on its own is not enough. People find ways around regulation. So for example, in Saudi, and I don't have numbers for this, but my personal experience is that you can now go into a pharmacy and there is a telemedicine clinic where you can basically phone into a prescriber and tell them that you're feeling ill, and it's not uncommon that they would give you an antibiotic. So regulation on its own wouldn't work if it's not coupled with a strong education component and a strong behavioral change component. This is also related to the capacity to do that. So this is from my work and my thesis on over-the-counter use of antibiotics in the Eastern Mediterranean region, where I evaluated for countries that have regulation on this, whether the regulation exists, what the regulation wording looked like in Arabic and in Pashto, which is for Afghanistan, and in Persian in Iran, and I translated them to English with the support of native speakers when needed. And there was also French, but I can do that. And the important aspect of the study was that many of the countries have regulations, but some of the regulations are maybe not super clear and need to be rewritten. And then I went on to evaluate how many of these countries actually implemented these regulations, and identified that many didn't. And I'm not going into details here, but what I found also was interesting is that I looked at the characteristics of the countries who, in general, and those who did not, had the highest reported non-prescription dispensing of antibiotics, were those with the lower GDP per capita, countries with lower pharmacist and physician to population ratios, and they had more out-of-pocket health expenditures, or had conflict or an economic crisis, meaning in those settings, people are more likely to go to pharmacies to get antibiotics because that's a backup for them. And also countries that didn't pass universal healthcare coverage legislation and had lower UHC indexes. So this, again, I just wanted to follow through from the previous concept of regulation, and that's regulation on its own. It can be really difficult to implement in the first place, and also isn't necessarily going to be impactful on its own. And that's why I really think that working on the quality of prescribing, and it's not just that I think the literature supports this, and I'm sure in Australia you have the experience to show this, and I'll let you speak about it, that working on the quality of prescribing is very important. Another study that I'll share that I think is very, very interesting was set in Peru, in a region called Iquitos, and they looked to evaluate antibiotic use to treat dysentery, diarrhea, acute lower respiratory tract infections, and fever in a community-based birth cohort in patients living with extreme poverty with access to universal healthcare. So they have access to universal healthcare. They're situation is uh, basically extreme poverty. And what they did is they looked at newborns and they followed up with them twice weekly for for the first 5 years of their life to evaluate if those patients ended up receiving antibiotics or not. This was just basically passive surveillance. And uh, what they identified is a child spent cumulatively around 4.3% of their first 5 years of life on antibiotics, which I thought was a very nice way to describe it, but it's also a lot. They also identified that the main prescribers were medical personnel. It wasn't the pharmacists, it wasn't the grandmothers, it was prescribers. And so the study's recommendation is to tailor interventions towards doctors and nurses, nurses for education, doctors for prescribing, and it may be more cost effective to do that versus doing a whole of population educational intervention, for example, in this setting. They also identified that duration of therapy was one of the really important interventions that could be avenues of where an intervention could be warranted, because at least 13% of the days in which children were on antibiotics could have been prevented if prescribers had followed the regulations, sorry, the guidelines, the local guidelines. And so a lot of the antimicrobial guidelines now focus on the shortest possible duration, and that's something that also is really important. So even if you are having a hard time with changing prescribing behavior about when to give an antibiotic, maybe focusing on how long to give the antibiotic in different settings could be really impactful. And these awesome authors also went on to think about, all right, but what about the argument of, well, the patients aren't going to take the recommendation of no antibiotic prescription, and they referenced a survey of 1,200 caregivers of children below the age of 5. So basically, parents of kids in vulnerable community, in the same vulnerable community, and they identified that through the survey that caregivers tended to respect a decision not to prescribe antibiotics if this recommendation came from a physician. So the excuse again, or the concern about patients demanding antibiotics again, is dispelled again in Peru. It is a completely different setting. So perhaps this is something to reevaluate and show prescribers that their perception may not necessarily be accurate. And even if it is, it's not the majority of the population. And perhaps even if it is the majority of the population, brief counseling may actually result in good outcome in terms of not asking or repeating the request for an antibiotic. But still, we have less AMS done in primary healthcare settings. And this is due to multiple factors, including the fact that primary healthcare clinics may be in different physical locations, you have different staff, you have less access and exposure to ID specialists, you're less likely to have dedicated stewardship personnel, and you may have incomplete documentation, such as for indication. You have wider variabilities in practice, and you're less likely to have microbiology and electronic systems. But if we go back to the first couple of slides, if we realize that most antibiotic use is used in upper respiratory tract infections and diarrhea and UTI, you may not need microbiology in all of those all the time, especially for upper respiratory tract infections. And you might have different accreditation standards between hospital and primary healthcare, requiring stewardship in hospital but not in primary healthcare. You can have different exposure to the concept of AMR because maybe primary physicians may not see as much resistant infections. And then the perception that they're using narrower spectrum antibiotics, so the role in AMR and stewardship may not be really clear. And also there is less experience with it. So eventually we have less literature. Other barriers are competing priorities, diabetes, obesity, opioid abuse in some places, and that AMR is not perceived as though it's important in primary healthcare and not as complex, so not as impactful, but clearly we may be wrong about that. The other thing is that, as I mentioned earlier, there may not be enough focus on primary healthcare stewardship in most accreditation standards, like Joint Commission International. Sibahi and Wiqaya are two, or the Public Health Authority are two accreditation standards in Saudi that don't explicitly focus on primary healthcare and stewardship, although the concept is there. However, in some other accreditation standards, I understand in Australia, but also in the European and US accreditation requirements to have some kind of evaluation or surveillance of antibiotic use in the outpatient setting in Europe, but also to have AmCare stewardship in the US starting in 2019. And so, also, what about the national action plans? Some countries actually do mention antimicrobial stewardship and primary healthcare in their national action plans. This is just, I didn't do the evaluation myself. This is from a document by the WHO, and they referenced only 4 of 11 Southeast Asian countries that explicitly mention primary healthcare in their NAPs. Korea, India, Indonesia, and the Maldives. So also, how do people and policymakers interact and perceive stewardship in primary healthcare? However, the similarities with hospital AMS are basically very strong because it's the same overall aim. You have the same problem-solving approach, so you need tailored interventions for the problem in that context. More or less the same knowledge. Of course, there are knowledge gaps, but it's the same general concepts. And there are a lot of tools that can be repurposed and concepts of behavioral change that can also be implemented. And similar monitoring approaches, albeit we might have to adjust the indicators, but in general, we have enough information to tell us where to start. So is it doable? And the answer is yes, it's doable, and it may be difficult to do at a large scale in all countries, but some countries can. This is an example of Bahrain's antimicrobial stewardship primary healthcare program, where Bahrain is a small island country, and they have universal healthcare coverage, and they implemented a large-scale intervention on stewardship from 2016 onwards. And as you can see in the beautiful graph, there is significant reduction in antibiotic use. And by the way, they didn't repurpose any specific funds for this. All of the stewardship efforts were done with no extra money, just bringing in stakeholders and getting people on board. And Dr. Jamila Salman, who was the primary author of this study, shared with us that they were able to get significant support from leadership from the king and the Shura Council to implement this because this was for the good of the population. And they were also able to show almost $11 million cost reduction. This is only by antibiotic use. They didn't look at potential revisits, or they just looked at overall antibiotic use. And I'll talk a little bit more about this study later. But also, just going back to basics on what are the aims of antimicrobial stewardship in primary healthcare, it's more or less the same as hospital: optimizing antimicrobial use, improving patient outcomes, reducing adverse effects related to antimicrobial use such and toxicity and AMR. And of course, there is a lot of work being done in Australia. So, like I said earlier, I'm not going to focus on that. And there are some general recommendations in some places, such as the US CDC, that have some suggestions on like, for example, the toolkit and how to approach stewardship. But I think that this also needs to be contextualized and thinking about, right, do we really need an ID expert in all settings? Could you maybe have a consultation with an ID expert on a regular basis rather than having someone in-house? The approach needs to be slightly different. And then how do we ensure sustainability of antimicrobial stewardship in PHCs? This specific evaluation looked at accreditation requirements. They identified funding as potential, of course, sustainability support, and then they identified that anytime an intervention is linked to quality improvement initiatives, that could be really helpful in ensuring sustainability. And complementary strategies focusing on clinician behavior, patient and family education, and partnerships. So these are things to consider whenever implementing primary healthcare stewardship. And then I just wanted to share a few very interesting opportunities that have been described in the literature and that are available, so such as the WHO Aware Antibiotic Book. In Australia, you have your guidelines. In other places, this could be a really good place to start by looking if there are no national guidelines using the WHO Aware Book. There are only 16 indications that require microbiology surveillance to optimize for local context. So really, this book is implementable in different settings. Uh, and the concept of we need to redevelop the same guidelines for that context maybe needs to be evaluated because in a lot of places, the main recommendation is to not give an antibiotic. So even if you just implemented that part, it could be very impactful. Other innovation approaches include looking at supply chain factors and antimicrobial stewardship. So a lot of in some countries you have antibiotics that are not available, then that's why people end up prescribing broader spectrum antibiotics. So if we fix that problem, then people are more likely to adhere to national guidelines. There are other innovative approaches focusing on specific indications like upper respiratory tract infections or UTI, and there's another study that I'll mention a little bit later. And there are also financial incentives, like in the country of Japan, they had implemented a financial incentive of an additional $7.3 to clinic providers to provide education, patient education, and to conduct shared decision making with parents of children between the age of 0 and 2 for upper respiratory tract infections and acute diarrhea. And what they found is that there was a significant reduction in prescriptions. Um, and then they also implemented another intervention where they provided communication training and that also reduced prescription rates in all age groups. And if you look at the Japanese guidelines, it's really interesting. It has the recommendation for the antibiotic, but it also has the communication strategy. And as I mentioned earlier, there are interventions that focus on specific infections, like, for example, looking at only UTI. And since this is a big bulk of antibiotic prescribing, this may not be a bad place to start in many settings. Of course, we can't talk about primary healthcare without talking about vaccination. So, what is the role of vaccination in reducing antibiotic use and AMR? Because effectively, you reduce viral infections, so you reduce exposure to healthcare, you reduce superimposed infections. And this evaluation by the WHO identified that just the use of existing vaccines may reduce AMR-related deaths significantly. And in addition to if that could be more cumulative and positively if we also consider early stage clinical development vaccines in the coming couple of years. And then very often a question is, all right, is this going to bring in money and or not? Is it financially interesting? And this is a systematic review, and they identified significant variation in how economic evaluation was conducted, and then they found that 6 studies showed that AMS interventions in PHCs were cost effective, and 6 studies showed that they were not cost effective or inconclusive. But they did find that communication skills training and CRP point of care testing were frequently cost effective and beneficial. And this really identifies like a gap in the literature, but also identifies that there are some things that we already know work, such as communication skills training and other point of care testing. So at the end of this talk, I just wanted to highlight that we know that primary healthcare settings are basically a good avenue to consider implementing stewardship in that setting. In settings like Australia, there are a lot of resources, but it's about potentially willpower, and I can't assume I know what it's like, but the guidelines are available, and sometimes work can be done in a collaborative way. And similar to this experience from Bahrain, where I co-authored it with Dr. Jamila, from the perspective of how can we actually implement the guidelines. And it's really mostly through persistence and through collaboration that the work can be done. And it's not just bringing in guidelines and recommendations and expecting people to follow them, but it's by very buzzy buzzwords like important co-creation, working together with the end users, the nurses included as well, of course. And one important part that I find missing often in the literature is the qualitative evaluation of how interventions were implemented. And this is why we put this together, which are basically what the team in Bahrain thought helped them. So leadership, commitment, and support, skills supporting implementation, careful planning and stakeholder involvement, as I mentioned earlier, problem solving for optimization. So anytime something would come up, they would fix it. Basically, that's it. But documenting those types of interventions are really important. And last but not least, ensuring sustainability of the interventions. So I hope that this presentation gave some exciting thoughts about how stewardship could be implemented in the primary healthcare setting. A lot of work is probably already ongoing without necessarily it being formally described as antimicrobial stewardship, and in many situations probably not described in the literature. There's not one way of implementing stewardship in general, and especially not in primary healthcare. And we know it's a collaborative effort, and that specifically in primary healthcare, there could be a lot of impact from this type of work. So I hope more people publish their work about, even if there are comments about processes and difficulties and barriers to implementation and not just outcome. I think I personally am very interested in that. And thank you so much for your time. Also, please reach out to me if you have any questions or if you wanted to discuss a little bit more. I look forward to hearing your feedback about my presentation. Thank you.
Thanks, Nour. So, yeah, unfortunately, Nour was unable to join us live today. She'd hoped to present this live, but due to the time difference, she'd planned to at least join us for the Q&A session. But again, due to a last-minute change of plans at work, she's actually mid-flight at the moment and sends her apologies. But if you have any questions or comments, please feel free to type them in the chat. We will forward your questions to Noor to answer at a later stage. So before we move on, I'd like to note that the next presentation will not be recorded, respecting the sensitive nature of the data as results are still in the preliminary stage. There will be an opportunity for questions at the end. All right, now allow me to introduce our next speaker. Maybe not at this stage, Ruby. It's a bit quiet in the chats at the moment. Oh, there might
There's
be something
a
in the
yeah,
Q&A. Yep.
yep.
There's a question from Nadine. So it says, fantastic presentation. Thank you. Just wondering if there was any discussion about the low uptake of nitrofurantoin prescribing and worries about compliance, frequency of dosing required.
Yeah, thanks, Nadine, for that question. You're actually really testing my memory. I think there were a lot of discussion around why nitrofurantoin wasn't prescribed. And perhaps Ron can actually answer that, because Ron was also in our webinar series, if he could remember what that conversation was about. But from memory, there were discussion about it. I can't 100% remember what they were. And there were some worries around frequency of dosing required as well, that Ron is nodding, because trimethoprim, I think, was a lot more popular because there was only one dosage per day for, I think it was 3 days. However, as we know, nitro and caprolexin, it's more than that. So they do tend to do trimethoprim. But however, there were also talk about, they weren't keen to use trimethoprim, but they would rather caprolexin, which is a much broader um, antibiotic that they use. Ron, do you remember or any of
Yeah,
that
that's right. Yeah,
discussion?
Ruby. Yeah, yeah. So I think we all know this. I think most people prefer to prescribe trimethoprim simply because it's much easier to dose. It feels almost. I think one of the comments says something around. It almost feels unkind to go, 4 times a day as opposed to once a day.
Yeah,
So yeah,
yeah,
that's exactly
yeah.
right.
But having
Um,
said that, Nadine, we know that the UTI have changed in the guideline, the recent TG guidelines. So it'll be very interesting because we plan to incorporate that into the next audit period. And we're going to be talking to our GPs at the next webinar about the changes. And let's see how that's going to work with the next change. So watch this space, and hopefully I'll be able to do the next lot of presentation on the results, and maybe we can even record that. So we'll see how we go. Leslie
thanks, Ruby. Yep.
also has a
Yep. So that's another
question.
question. Yeah, it's
Yep.
just several questions from Leslie. So it says, what a great study. Is this able to be scaled up to potentially encompass all GP practices? Is the first one. I'll let
Yep.
you answer that one first, Ruby.
Yeah. Look, I think the biggest failure of any study is not just the scalability, but it's the sustainability, as what Nour have been saying as well. For us to be sustainable, we if researchers can walk away from the study, so hands off from the study, and it still maintains and not drop off, that is the perfect outcome. However, in this case, we would like to scale it up, but right now extraction it's only within patron, so the granite data set. If there is a way that we can either install patron across every single general practice, or if there's another way that we can extract data easily and securely, because that's the biggest issue with data extraction, it's the privacy issue that they have. If we can do that, we can definitely apply algorithms to not just to those four conditions, but we could do more. So that was the first question. Could GPs
Yep.
be given
So,
guidelines to sorry,
yep.
yeah,
Sorry.
to continue
Second one
peer
is,
support? Yep,
so that's a, yeah, very good
yep,
question, isn't it?
yep.
Ruby.
Um, could they be given guidelines to continue peer support webinar? Possibly. Okay. So right now the biggest issue is that GPs don't get free therapeutic guidelines. So that's one problem. The second problem is if they could do that, they could possibly do something similar to what MPS did quite a few years back with either academic detailing or combined group support, peer support. So I think, that can be done, but at the moment, small steps. That's how I'm seeing it.
And just one last question from Shelley Naya. What about in aged care? GP who visits nursing homes, the approach on prescribing antibiotics?
Yeah, we haven't actually looked in aged care as yet, but it's something we are definitely very keen to move towards aged care as well. And we do have very good relationship with ANCAS and the aged care team as well. So hopefully we will be able to do that. But right now we just want to we really wanted to do a proof of concept whether algorithms work and whether it's acceptable within general practice in terms of the workflow, because the workflow is a little bit different in aged care as well. So definitely we can look at the algorithms or the guideline concordance in aged care as well.
Thanks, Ruby. That's a good comment here from Nadine saying we need a sustained release BD dosing nitrofurantoin in Australia, and we agree.
Yeah, agree.
Right.
Definitely.
It's 9:31 now, so I'm like close. Thank you, Ruby. And thank you everyone for your participation today. Again, as a reminder, you can send your questions through if you have questions about either Ruby or Noah's presentation. You can email it to us, and we are happy to forward them on. Just before we close, a quick reminder about our next webinar on the 21st of May. The topic is aged care, and this session will be chaired by Associate Professor Nolene Bennett. and we'll be joined by two exciting speakers, Dr. Stephanie Tenemis, who will be presenting on antimicrobial use in long-term care facilities measured by repeated point prevalence surveys, and Dr. Dipti Khatri on exploring the role of antibiograms as an antimicrobial stewardship tool in residential care, aged care facilities. We look forward to seeing you all there. Thank you for coming today and see you next time.